Hello, everyone, and happy Friday. My name is Liz Lazo on behalf of the National Alliance for HIV Education and Workforce Development, also known as NAHUD. I would like to welcome you all to our monthly Bridging HIV and Substance Use Disorder webinar series. If you have not done so already, please go ahead and add your name and organization name in the chat. We also would like to know what is your favorite ice cream or sorbet or ice flavor. So feel free to use the chat throughout the session to engage with your fellow participants. Throughout the session, if you have questions for our speakers, we ask that you use the Q&A pod. They will answer your questions during the Q&A portion of today's webinar. So before we get started, I just wanted to go ahead and go over some additional information. Also, just wanted to let everyone know that today's session is being recorded and will be added to the NAHUD website resource page along with the slides. So just to provide some background on NAHUD, if you're not familiar with our organization, we are a membership organization of 8 regional and 2 national AIDS education and training centers, also known as the AETCs. We were established in 2010. NAHUD supports the mission of the AETC program, a component of the HRSA-funded Ryan White HIV/AIDS program, which have an explicit directive to build and maintain a well-educated and culturally sensitive health professions workforce that can provide prevention, diagnosis, care and treatment, and medical management for people at risk for and living with HIV. NAHUD collaborates with multiple organizations in order to promote and educate on the work of the AETC program. Since 2018, NAHUD has been funded by the American Academy of Addiction Psychiatry, AAAP, as a partner organization of the Opioid Response Network, ORN, to address the intersection of HIV and opioid use disorder. ORN was created to support efforts in addressing the prevention, treatment, and recovery of opioid use disorder. ORN provides free resources and technical assistance locally in communities across the United States and its territories. So we welcome you to visit the ORN website for more information and or to submit a request for technical assistance. In terms of accreditation for today's session, the post-evaluation survey will be included. The link will be included at the end of today's webinar in the chat, and it will also be emailed to you within 1 day after today's session. We would love to have your feedback so we know how to move forward in the future with topics of interest as we continue our series. But also it's important that you complete it if you are looking for CME, CNE or social work credit, or if you're looking for a certificate of attendance. So once we are accredited today for 1.5 credits of each of those, and also you will receive your certificate within about 2 weeks after completing the evaluation. So at this time, I actually would like to, before I pass it over to our presenters, I'd just like to provide a little background on our presenters, starting with Eliza Morrison, who is the Assistant Director of Harm Reduction Services at the AIDS Support Group of Cape Cod. Eliza is a 12th generation Cape Codder with roots in the community which inspire her work as a harm reduction advocate. Eliza is a master Narcan trainer and frequently conducts community trainings related to agency services, as well as sitting on multiple service committees and advocacy groups locally to address substance use, housing, and human services. Eliza is a human services major with a focus in substance use. And also Bridget Volk has worked for the AIDS Support Group of Cape Cod since March 2021. She was recently promoted to the role of program manager in their prevention and screening department. Bridget received her undergraduate degree from UC Santa Cruz and recently graduated with a master's degree in public policy from UMass Dartmouth. She has professional experience working in criminal justice settings such as jails and drug court and with individuals who have co-occurring disorders. Her passion, however, lies in harm reduction work with her master's research project focusing on access to opioid overdose education and naloxone services. I apologize, I could not get that word out. But at this time, I would like to go ahead and pass it over to our speaker, starting with Eliza.
Thanks, Liz. I'm going to go ahead and I'm going to share my screen here. All right, greetings everyone. My name is Eliza Morrison. I am the Assistant Director of Harm Reduction Services at the AIDS Support Group of Cape Cod, and we're really grateful to be sharing with you for the second time today. We're going to have a presentation today about some innovations in the field of syringe service programming in rural communities with specific focus on mobile delivery of care. So the objectives today will just be a brief program overview of our prevention and screening services, just a brief intro and overview of harm reduction, a little bit of a data review, a regional Massachusetts data review, just an overview of our syringe service programs, and sharing some internal data. So I'll just begin with the mission statement of the AIDS Support Group of Cape Cod, or ASGCC, as we'll probably refer to from here out. Our mission is to save lives through prevention, education, and life-sustaining services that address public health crises to build healthy communities across the Cape and Islands. Some of our services include medical case management for folks who are living with HIV or AIDS, a food and nutrition program for the clients and participants that we serve, housing services specifically geared towards folks who are living with HIV/AIDS, and also folks who are at risk for overdose, experiencing substance use currently, or with a past history of some sort of high-risk overdose behaviors. We also have a prevention screening program, which provides cost-free testing services for HIV, hepatitis C, syphilis, gonorrhea, and chlamydia, and then linkage to care as well. All of our services are cost-free. We have offices in Provincetown, Falmouth, Hyannis, Vineyard Haven, as well as 2 mobile units where we deliver our services. Hang on one second. Sorry, I'm just going to click out of a little thing that's distracting on the screen here. So our prevention and screening services consist of HIV, hepatitis C, and STI counseling, testing, and referrals to treatment if folks desire to be treated. We provide access to PrEP, which is a daily prescription pill to prevent the acquisition of HIV, and PEP, which is a medication which, if taken within 72 hours of a potential exposure to HIV, reduces significantly somebody's risks of contracting. We also provide education programs on a one-to-one individual level and also in the community. We work very closely with IOPs and some rehabilitation facilities and sober homes in the community, as well as businesses, community organizations, etc. We provide opioid education and prevention, Narcan distribution, and sexual health training. We also are a syringe service program, so we provide access to sterile syringes, syringe disposal and retrieval services, as well as safer injection supplies. We also have a post-overdose support team, which helps individuals who are at risk of or have experienced overdose in the community, and also works to support first responders or anyone who may respond to overdose, as well as family members of people who have experienced an overdose. We have a mobile outreach vehicle that offers all of our prevention and screening services in Hyannis. So we have a small mobile outreach van with the capacity for delivering harm reduction supplies, trainings, and doing some sort of scaled down testing, linkage to care as well. We also have a larger mobile unit, which really caters to the Upper Cape and Falmouth areas, and that has a larger capacity for testing, et cetera, which you will see later in the presentation. We provide direct outreach to at-risk populations, so we do a lot of mobile outreach as well as street outreach, where we send teams of harm reduction specialists locally into different camps. They attend different like coffee hours and kind of public events where folks who are kind of our target population who we're hoping to serve kind of congregate. So we are wherever people who need our services are. We also provide linkage to care for addiction, including substance use treatment and same-day MOUD. We pride ourselves on utilizing a really low barrier harm reduction model delivery of care. So probably most of you are familiar with what harm reduction is, but here's just a brief overview. Harm reduction is really a non-judgmental, non-coercive provision of services to people who use drugs in order to assist them in reducing attendant harm. So what we don't do is we don't deny that using substances has very real consequences. Our job is to help and keep people safe and form better habits to keep them safe while they are still using substances. So we recognize that there are many, many factors which can determine whether people are ready to stop using substances or if they engage in treatment. Things like poverty, racism, trauma, discrimination, social inequities make people more vulnerable, and it affects their capacity to effectively deal with the harms that are associated with substance use. So our job really is to meet people where they're at. Our mobile delivery of services literally enables us to do so. So we can go out into camps, we can go out into communities, we meet people exactly where they are. It also means that emotionally we meet people where they're at. We do not require that people are abstinent in order to access any of the services that we provide. We aim to kind of fill that gray area between substance use and abstinence, keep people safe while they are using substances, form some safer, better habits, and be a supportive service and provide connection to folks who are using substances. Like I said, we don't attempt to minimize or ignore that there are real harms associated with licit and illicit substance use. Our goal is to just help to kind of minimize those risks. So just to provide a little bit of insight on some national involved overdose deaths, etc., I think Bridget is going to take the next couple of slides. Go ahead, Bridget.
Sure. Hi, everyone. I'm Bridget Bulk, Program Manager for 8th Support Group of Cape Cod. And thank you, Eliza, for that intro and a little bit of context on our agency. So here we have a graph that shows nationwide the drug-involved overdose deaths from 1999 to 2020. And as many of you may have heard or know already, the deaths have been increasing. If you look at 2020, obviously that's the year where COVID-19 hit the country, and we saw a pretty large increase in overdose deaths where maybe, agencies that providing our services, we did our best to get Narcan out there, but with the pandemic, it kind of changed our ability to deliver those services and affected people in a lot of different ways. So the point of this is that we are seeing an increase in the drug-involved overdose deaths, unfortunately. So next slide, please. Okay, so this just kind of explains a little bit further which substances were present in the deaths that occurred. So if you look at around 2015, 2016, that's when we first saw the introduction of fentanyl to the market. And fentanyl is a really strong synthetic opioid. So it's about 100 times more potent than heroin. And locally, what we're seeing in our landscape and what we hear from a lot of our participants is that, people really you can't find actual heroin locally anymore. So most, if not all, of what people are using is fentanyl, but around 2016 is when it first hit the market. And we used to have the multi-step assembly Narcan, which was a lower dosage and also a little bit more cumbersome to prepare and administer. So this epidemic really hit, and people may not have been as equipped to respond to it. But the Narcan we have now is 4 milligrams, I believe, in the single step nasal spray. So it works a lot better. We're doing our best to get it out into the community, but like I said, fentanyl is most of what we're seeing. We get reports also of, cocaine that contains trace amounts of fentanyl. And for cocaine or methamphetamine, or someone who maybe buys, an Adderall pill that they don't realize is a pressed pill, those people may be more opioid naive, which can put them at even greater risk to experience an overdose and subsequent opioid overdose death if they're not knowledgeable or don't really understand what's happening. So those are a lot of factors that could contribute to this, but mostly what we are seeing is fentanyl in our market. Next slide, please. So this narrows our focus a little bit more to Massachusetts. That's where our agency is. We're on Cape Cod, which is like the arm to the right, to the eastern side of Massachusetts. But If you look at 2020 and 2021, we are finally getting the data for that. There's a little bit lag in the data, but it is showing that the opioid-related overdose deaths are increasing. So as for us and our mobile services, we really understand the importance of continuing to get into the community and the boots on the ground type outreach that Eliza mentioned, meeting people where they're at. There's definitely still a need for that in our community. Next slide, please. Okay, so this shows nationally persons living with HIV infection. Oh, just kidding, Massachusetts. People living with HIV in Massachusetts, 2010 to 2019. You can see there is a slight increase. So for us, with our mobile outreach, we do provide the testing. A lot of these newly diagnosed cases are not being sexually transmitted. There's a higher rate of people transmitting who are those who inject drugs. So, in addition to our syringe services, we try to encourage people to get tested, to know their status, things like that. So it kind of ties into the mobile services we provide and, our overall mission of, yes, we will meet someone where they're at, but we also like to let people know about what services we have and kind of encourage people and empower them to take, some control of their health to be able to minimize harm or, risk of spreading to other people too. Next slide, please. So this is the number of confirmed in blue and probable in the green hepatitis C cases reported by year for Massachusetts, 2014 to 2018. It does look like we have a slight decrease, which is positive. We may attribute that to access to syringe service programs, to safer use supplies also. All of our services are really low barrier. When we test people, we always refer them to treatment, especially for hepatitis C. We've been doing a lot of work to connect people directly to providers locally that will treat them. We see a lot of different barriers. Sometimes it may be a place that requires you to have a primary care physician to order the appropriate blood work. So, we try to really figure out the best way and the best place to link someone to be able to actually access that care and start treatment as soon as they can. We remind people that, you don't need to be abstinent to start treatment for hepatitis C. And again, to encourage people to take care of their health. Next slide, please. So this is the reported acute hepatitis C infection cases for the US. So as we saw before in Massachusetts, there was a slight decrease, but if we look nationally, it does appear that the numbers are increasing. And for the acute cases, we consider that like a new infection. So within the first 6 months, so someone who's newly diagnosed with hep C, we attribute the difference in the numbers in Massachusetts to, really low barrier models of delivering services, which does include the mobile outreach that we do and the ability to, bring a van somewhere and have a place where someone can come on the van and get tested like right there. Basically as many steps as we can eliminate for someone to get tested, the better. So we really try to make it accessible, low barrier, and we find that to be effective for us where we are. Next slide. All right, I think now Eliza is going to take this back and talk a little bit more about the syringe service programs.
Sure. So I'm going to talk a little bit about our syringe service programming and just syringe service programs in general. So over the past 30 years, research has shown that comprehensive SSPs are safe, effective, and cost saving. So SSPs or syringe service programs are evidence-based interventions that decrease the incidence of HIV and hepatitis C. Obviously, because when folks are not sharing syringes, there's less risk of transmission. Our particular exchange, we do not have a one-to-one model. A lot of agencies will do like a one-for-one where you are, where if you receive 10 syringes, you need to bring 10 back. We will always give folks as many supplies as they need. SSPs also decrease costs associated with HIV and hepatitis C treatment over the course of somebody who's living with HIV or hepatitis C. The costs associated with them using a syringe service program to stay free of HIV or hepatitis C are far, far lower, pennies on the dollar, compared to what it costs to treat HIV. To treat hepatitis C or to treat or manage HIV over the course of an individual's lifetime. People who engage with syringe service programs are 5 times more likely to enter substance use treatment. So what we really find is that when we meet people where they're at, using our harm reduction model, we engage with folks in a non-judgmental way that creates a relationship that keeps them coming back. Maybe initially it's because they need Narcan, maybe they need syringes, perhaps they have an abscess, associated with soft tissue infection or injection drug use. They're afraid to go to their practitioner because they've experienced stigma in the medical community before. So we really act as kind of that bridge to services that folks may not have accessed in the past due to stigma, financial issues, lack of insurance, lack of transportation, all of those things. So we build these relationships with folks where when they're ready, they feel comfortable approaching us. Hey, I'm ready to start talking about maybe getting a primary care provider. I'm ready to do some HIV, hepatitis C testing. I'm ready to try Suboxone or methadone or whatever it is. So we provide that connection. We're really kind of healthcare for people who use drugs. SSPs reduce the amount of discarded syringes in the community. So not only do we provide mobile pickup services, and that's not only for people who use illicit substances. This is for folks who are, diabetic, people who use like hormone injections, for medical purposes as well. We send outreach folks out on sweeps where we, kind of sweep the community or where we know that people might be using syringes and make sure that there are none in the area. If there are folks in the community that call us and they say, hey, I found a syringe on my property, we're happy to go out and properly dispose of that. So it really, and a lot of our clients will not drive with syringes or, drug paraphernalia in their vehicle for a multitude of reasons. So we offer to go out to their homes and we pick up their used syringes and provide them with clean supplies. And so that works really well to keep the community free of syringes. It reduces needle stick injuries to first responders. We provide them with disposal containers, etc. So people don't often have, syringes that perhaps are on their person or out where somebody could, accidentally be stuck. And syringe service programs do not increase crime in areas where they are located. So what do we do at a syringe service program? We attempt to reduce the harms that are associated with drug use. So all of our harm reduction staff is trained in how to talk to people about wound care, safer injection, fentanyl testing, overdose recognition and response, etc. We provide safe injection supplies and we serve as a place for connection and linkage to care and treatment. We provide education on how to prevent contraction of communicable diseases and how to prevent soft tissue and other infections. Inevitably, many times those infections do happen anyway. We can help people access care for those things. And we also provide, wound care kits and supplies and education on how to, keep things clean and how to recognize signs of infection and when it's time to see a doctor and when they might be in kind of like a danger zone with those things. Like I said, we provide safe disposal and retrieval of syringes, and it's a vital public safety resource. We are a welcoming and safe space for individuals, and we provide referrals for all things that are health related. So lots of times people just come, I mean, even after they have begun to experience a period of abstinence, we have a lot of participants that will still come and visit us. We're their safe space and kind of become, you know, a big family or an extension of their support network. Here's what currently the syringe service programs in Massachusetts look like. There may be a few more currently. Our office in Hyannis here is not shown as we are not funded by the Department of Public Health currently, because we do not yet have town approval, but syringe service programming is legal in the state of Massachusetts. So we continue to operate in Hyannis. We are just not represented by a little pinpoint here on this map. But as you can see, Massachusetts has a robust syringe service program. So here's some of our harm reduction service data. In 2022, individuals who accessed our syringe services, the number was 817, and this is across all of our sites. We collected 117,435 syringes. We conducted approximately 120 community trainings over Cape Cod. That's, you know, out in the community and also over Zoom for larger audiences. The number of participants that we trained is about 1,200, but probably greater than that. We distributed 4,681 doses of Narcan. So those are some pretty significant, numbers. All right, so I'm going to go ahead and I'm going to turn this next section over to Bridget, who's going to talk about our mobile services a little bit.
Great, thank you, Eliza. Hi again, everyone. So for my portion, we're going to talk about what services are offered on our mobile units, ways we collaborate, some existing partnerships in the community. I have a little bit of data for us from this fiscal year, different challenges, local spotlight, and there's a few participant experiences shared throughout. So, okay, so this is a picture of our van all set up. So we provide all of the other prevention and screening services mentioned in the beginning of this presentation. So that would be our STI and HIV Hep C testing. We test for HIV, Hep C, syphilis, chlamydia, and gonorrhea. And with any testing or syringe exchange, we do a comprehensive risk assessment. So we're not just, you know, having someone come in to access syringes or safer smoking supplies, you know, and then be on their way. We really try to sit down with people and kind of talk and get a holistic picture of what's happening for them in their life. We can do Narcan trainings. We give out Narcan on the van. We provide all of our syringe services. And we also provide fentanyl test strips, fentanyl test kits. We try to educate people about that. Like I said, in our drug market, there's been fentanyl found to be contaminating different substances. And then, of course, we will do referrals to medical, mental health, or substance use services, really depending on what the person's needs are. So for collaboration with community partners, we collaborate with substance use treatment centers. So on Cape Cod, we do have a detox facility. There's several other treatment programs. So there's a few residential programs we will go to. There's a PHP, IOP combination. That's a really popular model. We have now 3 of those that we are serving in different outpatient atmospheres where, you know, our target populations may be. For the service organizations, we work with different housing authorities, transitional services, shelters, different charitable organizations. We do collaborate and do, you know, trainings with Narcan for law enforcement or first responders. We have a really positive relationship with them, which is great. With boards of health, Eliza might talk more about the Falmouth decision that happened a few years back. And then in Sandwich, we were able to get town approval to provide the services. We work with different churches or spiritual groups. We have the local Wampanoag tribe, and we're connected with them too through some organizations, criminal justice, the courthouses, and, you know, community health centers local to whichever site we're at. So existing partnerships, this is a shot of inside of the van, some of the artwork there in one of our little testing areas. So we do weekly test and train events at treatment facilities. So we'll go in, we'll bring the van and we go inside the facility and we switch off. We provide a Narcan training, opioid education, Narcan training 1 week. And then the next week we'll do sexual health training to talk about the different things we test for, some other information. We will talk about PrEP and PEP for those who may be interested. So we do those events. We also have weekly scheduled parking spots that we will bring our van to. There's a recovery gym we will go to. The Falmouth Service Center is really great. They do a food pantry. So we'll go there a few times a week now. Just again, trying to reach our target population and the different spiritual groups that we're able to park our van at. And all of that came through a lot of community outreach, just being in the community and doing our work and, you know, people noticing and realizing that it has a positive impact on our community. We also attend different, you know, commissions or town groups associated with substance use. So in Falmouth, it's the Substance Use Commission. We're present on those meetings and in the committees, and people really value our feedback. Like I said, we're really the boots on the ground for a lot of the people that we're serving. We collaborate with local sober homes. Falmouth is really unique in that there's a really large amount of sober homes in that one town compared to any other town in Barnstable County. So it's a really densely populated area with people, you know, in recovery or like maybe still in use or have returned to use from a period of abstinence. So lots of people that we can assist. And then recently we've been reaching out to our schools to try to educate and teach about Narcan. Okay, so more local organizations. We've done trainings with the Fishing Partnership. They are a secondary distributor of Narcan, and we can train people how to train their staff or their clients and how to use Narcan too. So a lot of the information, you know, we pass on, people can use to help their own organizations. We also participate in the Falmouth Essential Services Network. That's a lot of different people from human resources and housing. In Falmouth, there's no shelter, and there really are not a lot of services for people who are unhoused. For the winter months, what they'll do is they have emergency hotels that they will put people up in, but it has to be below a certain temperature or, you know, an extreme weather event for them to do that. And even when they do that, there may be some individuals that we serve that are on a do not rent list, where the hotels will not let them stay. So our role is really imperative in that, you know, we can advocate for those people, people who may not have an ID, who can't get into those shelters. We can kind of work with them and try to figure out a solution for them. Since we don't have a shelter, people don't have a place to regularly shower. So we were able to collaborate with a local gym with the guy who runs it is really nice and has been really gracious with us. And we developed a shower program where, you know, we have a time once a week where people can go. We got a lot of donations for, you know, toiletries, showering supplies, and clothing donations as well for people who may be living outside. So now we have that relationship and that's been going on for a while. We collaborate with our local methadone clinics. And like Eliza said before, just the boots on the ground outreach is pretty invaluable. So just a little bit of testing data for this year. Like I said, we do the testing events at the 3 local treatment centers. We provide it at the Falmouth Service Center and the Wellstrung Gym. So you can see we are testing, you know, pretty good amount of people. Throughout the summer months, we may see more people just based on, you know, the Cape Cod. The amount of people here in winter versus summer is kind of, there's a big difference there. We are working to develop our hepatitis C linkage process. We've been working with a group to develop a process map, and that way each one of our harm reduction specialists has a guide to, you know, if this person tests positive, what do I do next? You know, do they have insurance? Which place might be the best for them to go, you know, talk about treatment and to actually start receiving that treatment and complete treatment. And we've done 125 tests. This was as of February. We had done 125 tests for the fiscal year, which we're now seeing an increase for this year compared to last year. All right, so this is our Narcan data from July to February. So the smaller numbers are the amount of encounters, and then that's the amount of doses we've distributed. So we're getting a lot of Narcan into the community, which has been incredible. We collaborate with different sober homes, recovery centers, different groups, and just our regular people who access syringes. Okay, so community education data. So we mentioned the trainings. There's a number of trainings and number of participants. I believe January was high. We do a few community trainings sometimes. We were able to do a staff training for one of the tech high schools out here where, you know, they invited all of their staff and administration to attend this Narcan training. So we've seen a really positive response with that. Okay, so short-term health navigation, we've been talking a little bit about linkage to care and our comprehensive risk assessments that we do with people. So this is defined as navigations for people with positive HIV, Hep C, or STI results and or who have a high risk of acquisition or transmission for those. So really, most people accessing our services will fall into this category. What we do is we facilitate linkage to care or treatment completion for HIV, Hep C, and other STIs. For HIV, we do have a medical case management department within our organization. So we will refer, you know, in organization to one of our case managers and get people taken care of. And like I said, we put a lot of work into the Hep C linkage, and hopefully our wish is someday to have a provider internally that can start prescribing to treat, but that's to come down the road, and we don't have that figured out quite yet. We also make it a point to have same-day MLUD access. We have really good relationships with the health centers locally, so you know we have ways to put a call in or get a telehealth appointment for someone so they can access that same day, because we know how important that is for someone, and you know really anything we can do to decrease risk of an opioid overdose, we will do. All right, and then any other things like housing, mental health services. There's a lot of different categories for that. We give people cell phones sometimes if they don't have cell phones. We were able to do that because how hard is it to get an appointment somewhere if you don't have a number to call someone back on? But here we have a participant experience. I'll just read this. He stated accessing our services, he said, "It was amazing how convenient it was. They hooked me up with every service I wanted. I could never get more than 1 to 2 things done, but they listened and took care of me. I was paranoid at first and a little freaked out, but she made me feel calm and accepted. I was able to get things off my chest. They referred me for mental health and my trauma and helped make sure I followed through. The delivery service was amazing because I didn't have to feel ashamed or like they're judging you when you go to a pharmacy to access syringes. I didn't even know all the supplies and stuff or that they delivered. They made sure I had plenty of Narcan and taught me how to be more safe. I gave some Narcan to a friend who ended up using it on his brother, and his brother had used it on him a few days later." All right, so different challenges we see. We are a rural community, so access to services, the public transport on Cape Cod is really not great for people who are unhoused. Even if they have Mass Health, there's something called a PT1 where you call ahead for a ride to a medical appointment. But if people don't have an address, they can't access that service. So we really struggle with that. People who are unhoused or already in need of resources, there's a housing crisis here where there are not really many units available at all. So people may have a housing voucher that they have to get extended because they've not been able to secure an actual residence. And then also for people we try to reach, many individuals are using it at home. It can be difficult to find and reach that demographic of people. Of course, stigma for someone accessing the services to begin with. And then the stigma as an agency of providing syringe services. You know, some people still may respond negatively or think, you know, it doesn't happen in my backyard, or, you know, although in Massachusetts, as stated before, the syringe service programs have state approval to operate. What we try to do is meet with the town boards of health just to explain our services, answer any questions, kind of like provide more of a picture of the data and research behind a syringe service program and how it does benefit the community. And we've been successful in receiving that support. So we try to build agency awareness through outreach, reaching out to different community organizations, and we identify and eliminate barriers for individuals accessing services. So people who may not be engaged in healthcare, or, you know, we try to help. There's it can be difficult to get even a primary care provider on the Cape. So we try to, help people figure out that sort of stuff. So as a result of COVID-19, it kind of reshaped how we delivered our services. People became more isolated, understandably. So we literally were meeting people where they are at. So in addition to our mobile outreach vehicle, we offer home deliveries. So those we will do in smaller agency vehicles. Our van, as you saw, is, a big white van. So it's, we don't necessarily want to bring that to people's residences, and we respect people's desire to be anonymous or discreet. So there's a lot of advantages to that. People who may not be able to get out of their house, they can now access our services. Okay. So how do we address these challenges? We continue to collaborate with local agencies, establishing an understanding of what certain service programs offer and why harm reduction is important for prevention and treatment, just creating awareness. I think there's a lot of resources out there dedicated to, treatment and achieving some sort of recovery, but we find that our niche is in those people who may still be using substances and who might not currently have the desire to stop using, or might never have the desire to stop using substances. But we try to, we recognize that those people can still have dignity. They can still make decisions for themselves. They still should be afforded housing. Abstinence should not be a requirement to access housing or medical treatment, or, just to be respected. So that's really the niche we try to fill. We have the post overdose program. We, try to do a warm handoff, and we continue to do outreach work. So this is just a picture of the outreach bags that we put together in the winter. We were able to purchase sleeping bags, hand warmers, blankets, socks, any sort of toiletry you can imagine, beanies, scarves. Like I said, we have the prepaid mobile phones we're able to provide to people to keep them engaged in services, referral to testing or treatment, and just continue to show up for these people where, they may not have had anyone showing up for them for quite some time. Next, please. Okay, so local media spotlight. Eliza is going to talk more later about, the Falmouth decision and some stuff that happened with that. But we've been, being received really well in the community lately, which is incredible. I think there's been a little bit of shift in the stigma in providing these services, and especially with the increased overdose death rates. I think, people recognize the importance of our agency and what we do. So we have been able to introduce the mobile outreach vehicle and services to the community. The low threshold, low barrier model is helpful. There's a link to the article. I think the slides will be shared too. So if anyone would like to read it, that's our van in the local newspaper in the picture. And we have a piece in the Falmouth Community Television monthly series coming up as well, with myself and our CEO being interviewed. And that's myself and then one of our harm reduction specialists on our van. And another participant experience. So I asked him to describe, what it was like being able to access our services. And he said it was a combination of feelings, honestly, relief and anger, overwhelmed, what was left of my central nervous system. I was relieved that I did not have to, remove everything that was barricading my front door and somehow crawl to the pharmacy to purchase syringes. He said he felt so low and isolated and didn't care if something bad happened to him. But the people who delivered his supplies went above and beyond. I accessed this service multiple times and eventually got hooked up with more services. They helped me in one of the darkest times of my life, and I will forever be grateful. All right, so that's it for my portion. Another picture of our van there at our service center, and I believe we're doing questions in the Q&A. So that's it for my portion, and I'll hand it over to Eliza.
Thanks, Bridge. So I'm just going to talk a little bit about what it has been like to establish syringe service programming in rural Massachusetts. So Cape Cod is can be a pretty kind of isolating geography here. We really are kind of like this arm shape. And so many times the substances that come to the Cape will funnel down from larger cities. And so we will kind of see these times where we're seeing some very strong substances, and really what substances end up on the Cape are what end up here. So our participants don't oftentimes have the ability to, like a good harm reduction suggestion for folks who are using a substance that is too strong, perhaps causing skin infection, perhaps they're having some other like tranquilized reaction as well. People here don't have the option to change their dealer, whereas somebody else living off Cape might have that option. So you know, a lot of folks on Cape Cod also don't have access to transportation. It can be very, very isolating. So there are numerous barriers to establishing SSPs in rural Massachusetts. So I'm just going to give you a little bit of history on what that looks like. So the state of Massachusetts approved in 1993 10 pilot syringe services programs. So under what that looked like was under physicians' oversight, they would be providing syringe service programs, which would include a treatment and education component. So they were really tasked with anybody who came to seek syringe service supplies would be provided with education about HIV, safer injection, safe disposal, etc. So any town in Massachusetts which received local approval from the select board or town council members was able to start up one of these syringe service programs. So only they were approved for 10, but it took a very long time to actually get that number of towns on board. So this was in 1993. And the data that was being collected on newly acquired HIV infections via sexual transmission was on the decline. And what they were starting to see is that these newly acquired HIV infections were really the result of syringe sharing and you know, injection drug use. So syringe service programming was sort of their tentative answer to starting to curb these new HIV infections that were becoming a result of injection drug use. So this is just a chart here to show in the US from 1985 to 2015 what the mode of transmission looked like. So you can see here that in 85, obviously the male-to-male sexual contact transmission line here starts to take a dip right around 1993. And then injection drug use in 1993 as a cause of HIV contraction started to rise. And then heterosexual contact was also on the rise there. So some of the barriers, obviously, that you know, different towns run up against when establishing syringe service programs are, number one, stigma. There's a lot of stigma associated with, obviously, substance use in general, but then also being perceived as being permissive of substance use. There's a lot of kind of misinformation around harm reduction and syringe service programming, that it maybe encourages people to use substances that we know obviously is not true. But in turn, this would oftentimes result in the failure to obtain approval from the different municipalities. So although HIV transmission, according to CDC data, via injection drug use was on the rise in the 90s. The 90s were still very much entrenched in abstinence-based programming like DARE, the war on drugs, and just saying no. So it was really hard to break through that, even as a public health initiative. So pushback was really common when approaching any municipality with, they felt that it was very counterintuitive to, you know, these abstinence-based programs. So between 1994 and 1996, they were able to establish 4 syringe service programs in Massachusetts. One was in Northampton, Mass., one was in Boston, one was in Cambridge, and then one was in Provincetown. So the Provincetown Syringe Service Program was a branch of the AIDS, it was the original branch of the AIDS support group of Cape Cod. So we became the only approved syringe service program Cape Cod. And we had already kind of been trying to manage and cope with and provide support for the HIV/AIDS epidemic. So the AIDS support group was established in the 80s, about 10 years prior to our approval for syringe service programming. It was formed by a group of volunteers in response to the emerging AIDS epidemic. Our model is based in harm reduction, as we've said before. They were focused on the prevention of acquisition of new infection and case management and assistance for folks who are already living with HIV and AIDS. So the data then began to shift in these new infections and reflect an increase in people who were injecting drugs. So the agency knew that they had to kind of shift their response to include folks who were at risk from injection drug use. So Provincetown was one of the 4 early established SSP sites between 94 and 96, and also began to incorporate the screening process that Bridget discussed earlier, kind of our intake process and counseling in its programming. So we really we're getting to know these participants on kind of a more intimate level. So not only are we talking about maybe some of their substance use, but we're talking about sexual history. We're talking about harm reduction. We're talking about where are you housed? Who are your supports? What are your risk factors, et cetera. So kind of taking this whole person approach to an intake and to providing services. So as we talked about, it kind of always is a little bit of a tussle to get our services approved in different communities for many different reasons. But in 2006 in Massachusetts, all of the prohibitions and restrictions on possessing and distributing syringes were removed. So this then meant that it was perfectly legal to carry syringes on your person or to distribute them. If you have syringes, you could then distribute them in the community. You could distribute them to friends, family, at free of persecution. And this was kind of in an attempt to make syringes just more accessible to folks and decrease syringe sharing. Hyannis, Massachusetts, where our second site was opened for ASGCC, was designated an opiate use hotspot in 2009. So we were able to open our first syringe service program there in Hyannis. And so we were not able to, in a historic kind of court battle, we were not able to obtain approval from the Board of Health, but because syringe service are legal in Massachusetts through kind of like this historic court battle, we were able to, in 2015, keep our doors open. So the health department had issued a cease and desist order in 2015 on the syringe services program there, but then ASG went to bat for the people that they were serving, and for syringe services in general were represented by GLAAD and the AIDS Action Committee in kind of like this groundbreaking court case where we were granted permission to keep our doors open because our programming was proven to be useful and effective. So as a result of this ruling, that kind of paved the way for the number of syringe service programs to grow in Massachusetts because the barriers and the bar were further lowered. So this is what the syringe service programs in Massachusetts looked like as of 2015. So as you can see, there are 5. The Hyannis site is not represented here because, again, because there is not Board of Health approval at that particular site, that site does not receive funding from the Department of Public Health. So that is not notated on the map there. But after this kind of historic groundbreaking court case, which kind of opened the doors for syringe services in Massachusetts as of 2018, this is now what syringe services look like in Massachusetts. So we feel really lucky to have been part of kind of paving the way to get all of these much needed programs into some of the more rural areas of Massachusetts, who now have some really robust syringe service programming. So just kind of, in the same vein of, fighting for approval in different towns, Bridget, who spoke a little bit about our, or she spoke at length, but she kind of touched on what it was like to integrate our mobile services into the Falmouth community. So in December 2018, we went before the Board of Health in the town of Falmouth, and we secured approval for a site in Falmouth, Massachusetts, which basically meant our agency went before the Board of Health. We provided information about our services, provided data locally about, opiate use, overdose, and how those things can be improved when a syringe service program comes to your town. Although Falmouth was the town on Cape Cod that was ranked highest in overdoses on Cape Cod in 2017, there were many town members who found out about this Board of Health approval and began a very kind of like aggressive and lengthy pushback process. Like Bridget touched on, Falmouth is a town that houses a lot of inpatient, outpatient programs that are abstinence-based, and also a big sober housing community. So this was sort of difficult for people to stomach that perhaps a syringe service program was coming to their town. There was a lot of the not in my backyard mentality. In 2013 to 2018, police had responded to 665 overdoses in the town of Falmouth, and 55 of those were fatal. That number is probably a lot larger. We know that with overdose, those are 665 reported overdoses. There are a lot where people respond at home, and those never actually get reported. So social media and social networks were kind of buzzing with all of this misinformation about harm reduction, syringe services, what that looks like in your town, etc. And so in the best interest of establishing a good relationship with the town of Falmouth, we decided to kind of shift our gears and kind of shift our focus. Instead of securing a larger kind of centrally located front-facing syringe services program in a brick and mortar facility, we decided to focus on providing mobile services. So that's where the larger mobile van unit comes into play. And this is just a little bit of data by Cape Cod town in the years 2016 and 2017. We can see that Barnstable, where our Hyannis office is located, these are the deaths in 2016. These are the deaths in 2017. You can see that obviously Barnstable is one of the highest, but Falmouth is actually ranked highest in deaths in 2017. So they were much needed services to be delivered to Falmouth. And this is where the mobile unit was born. So we knew that the services were necessary. Falmouth has the only treatment facility on Cape Cod. So meaning it is an inpatient detox. And there are lots of sober homes, IOPs, like we discussed. We spent a lot of time as an agency providing education in like open forums to the community. We hosted some town meetings. We gave people an opportunity to ask us questions and to educate them on harm reduction services and syringe service programs. We educated and integrated ourselves into partner agencies, so forming relationships with some of the healthcare facilities locally and some of the recovery based abstinence-based services in the community, and just really made an effort to show them how harm reduction and our services can promote, can promote healthcare and well-being of the people that we're serving. Obviously, we know that anybody who has experienced a period of abstinence, whether they intend to remain abstinent or, they have a brief return to use, that those folks are at the highest risk for overdose. So we really wanted to make it clear that we were there to support the folks who are at the highest risk in that community. So we got pretty creative with our service delivery in Falmouth, and that resulted in the mobile unit that Bridget was referring to. So there's our mobile unit. There's capacity for testing in the back. There's also capacity for intake and testing in the front. There's a restroom on there, as well as space to store syringe service supplies, harm reduction supplies, etc. So we can really provide all of our services there on the van. So we just talked a little bit about what that's like inside. We offer all of our testing services on there. We make referrals to short-term health navigation. We can provide transportation, all of the services that Bridget was talking about. So just kind of when we had finished up in Falmouth, kind of integrated our services into the community in the fall of 2021, Sandwich, another rural village close by, just kind of outside of Falmouth, was identified as another hotspot, and that syringe services were needed in that area. So it's a large town with very few accessible services, no real town center, many affluent homes, and many people who use drugs who were accessing services through our other sites, but really didn't have means to receive services in the town that they were living in. When we presented to the Sandwich Board of Health, they unanimously approved syringe service programming in their town. But then once again, rumors, misinformation were swirling on social media. We were kind of being attacked once again from all angles. But we continued to provide our services in Sandwich, just being more mindful of the locations and the organizations that we were working with. And we are continuing to educate and establish relationships with local organizations. So that's just another example of a, breaking through that stigma and being able to educate a town and provide services in the community while kind of trying to create a sustainable and amicable relationship. As Bridget touched on a little bit, COVID really forced a change in the way that we were delivering services. So our Hyannis site, which was serving the largest part of Cape Cod at that time when COVID hit, because Falmouth was not quite up and running, had to briefly close their doors when COVID hit. And that was kind of orders from DPH. But we knew that it was going to be imperative that we were staying connected with our participants, being that we really were we really are the only kind of linkage to support and care for a lot of our folks. So we started a delivery and pickup service, which kind of consisted of like sort of a triage where, we would get a call into the office from a participant. They were able to text us on specific phone numbers. The kind of call to action would go out, and one of our harm reduction specialists would gather supplies and go out to meet clients, safely distanced, assess needs, do another kind of like little boots on the ground evaluation with folks, but to continue to stay connected and deliver services. Again, we were giving people cell phones. We were providing connection to people who needed kind of emergency housing. During COVID, one of the things that we really saw was a need for emergent housing because people who were in kind of unstable or volatile housing situations, maybe with partners who were unstable or unsafe, suddenly the world kind of shut down. They were together 24/7. Sometimes substance use got worse. Sometimes they did not have access to substances, so they were experiencing withdrawal, maybe some other mental health stuff. But we saw a real increase in kind of like friction with people living in the same homes, some partner violence, etc. So we were able to provide kind of some respite housing and some separation for some folks who really needed it during that time. And that happened because we were able to stay connected with those folks. We were accessing people now that we had not been able to serve prior to our mobile delivery of services because they were concerned about coming to our agency and, maybe being seen at the Syringe service program. Perhaps they were concerned about transporting supplies, etc. So we started to connect with folks that we had not connected with before because now we could discreetly and confidentially deliver and pick up items for folks. So we made many new participants during that time. And we decided that this model of delivery was successful and that we were going to continue it at all sites, and we have. So this is a photograph of our mobile unit in Hyannis. It looks a little different than the mobile unit in Falmouth. It's a lot smaller. It still does have the capacity for some testing. We do not do any of our gonorrhea chlamydia testing unless it's an oral swab on this unit because we don't have a bathroom, but we can distribute supplies. We have a MOU with a local healthcare center, so Duffy Healthcare. And that enables us to have a recovery support navigator on our van sometimes who can link people to insurance, connect people to same-day care, assess folks for, physical and mental health needs, and link them to services if need be. We provide our syringe services and harm reduction supplies and education from this smaller van as well. We also have a really nice partnership with the local methadone clinic where we go every other week and we park the van for an amount of time there and provide all of our services in their parking lot. We also provide most of our delivery on this van as it is a little bit more discreet than the larger van in Falmouth. So again, this is just an overview of our services that we provide. And that's a wrap on that for me. So I'm going to stop sharing my screen. I appreciate you guys having us here so much today. We love an opportunity to talk about our services. I guess we will open it up to questions or however Liz wants to do that.
Thank you, Eliza and Bridget. That was fabulous. A lot of great information and really a great model, as someone had mentioned in the chat. And it really sparked a lot of conversation in the chat. So thank you all for your engagement there. We do have several questions in our Q&A. So if you like, I can read them off to you guys and you guys can go ahead and address them as you see fit. So starting with our first question is the SSP providing safer smoking supplies as well? I know folks at SmokeWorks Boston are assisting with providing meth pipes, hammer pipes, and crack stems.
Yeah, I'll answer that. Yes, we are. So we work with SmokeWorks. We love those guys. And yes, we are. We're providing, the Department of Public Health is now funding our programming to supply safer smoking supplies because we know that number one, folks who are smoking crack, smoking meth, etc., are also at risk for overdose because of the contaminated drug supply that we have here. So those folks are all now at high risk for overdose, and being able to provide them with safer smoking supplies creates a connection with a whole new demographic of people that we may not have been seeing before. So that's great, as well as the fact that safer smoking supplies also prevent the transmission of HIV and hepatitis C. So yes, we do provide safer smoking supplies on our vans, in our offices, everywhere.
Do you collect or share data regarding participant connections to care, including treatment for substance use disorder, MOUD, or other options?
Go ahead, Rich.
Yeah. So we do that. I would relate it to our short-term health navigation. So we have several ways we collect data within our agency. So we track every syringe exchange or safer use supply exchange. And in that, it will ask us which referrals we did. And then specifically internally, if it's like a substance use disorder referral, we'll write what sort, whether it was like an ATS bed or, referral to MLUD. We'll write that in our notes. We usually write where we refer people to, just so we have like all of that data available. But we do track that. The state, we are funded through the state to provide the short-term health navigations as well. So we really try to connect people if we can, and we track it all.
Are you using xylazine test strips or planning to use these in the near future?
I'll take it. Yeah, so I actually just was featured in the Cape Cod Times along with one of our partners at Duffy Healthcare, who just did a big article about xylazine and kind of like what we're seeing here on Cape Cod. So the thing about xylazine test strips is right now they are only designated for forensic use. So meaning they are only to be used to test like bodily fluids for positive xylazine. There is some information that shows that, using those test strips on the substances themselves is fairly accurate. So currently we are not using xylazine test strips. They're cost prohibitive. They are not, the kind of jury is still out on how effective they are. But we do have access to drug checking through a program that we work with in the state of Massachusetts. It is not on site, but we are able to send samples to a lab and have them analyzed. It's not as helpful kind of like in the short term as far as people who are like actively using, but it is helpful to kind of like track what's in our drug stream. We are not seeing, so last summer we saw a lot of xylazine. We were seeing kind of like the whole nine with the wounds and also with the real tranquilized effect that was kind of like going along with using the fentanyl that had xylazine in it. That kind of tapered off and we haven't seen so much, but it is coming back. So we are starting to see it again, and that will happen oftentimes on Cape Cod. So we're definitely trying to stay on top of all things xylazine. Unfortunately, like a lot of our folks have a really hard time engaging in care, and these wounds that we're seeing as a result of injection substance use, where xylazine is involved, are really, really hard to manage without medical care. So working to create relationships and partnerships with healthcare facilities who are local to us and, who try to create a low barrier and stigma-free environment for folks and who are willing to see folks perhaps same day or even, telehealth or come to our office to meet and assess, et cetera. Those are the things that we can do right now in the now. And obviously educating people on what, how it looks different responding to an overdose where xylazine is on board. So yeah, no xylazine test strips as of yet. There's no doubt in my mind that they are going to have to really, step it up when it comes to that. So hopefully soon.
Thank you. Is there targeted outreach to reach people who engage in ChemSeps?
I can answer that one. I feel like, so that probably has a lot to do with our Provincetown office. So I talked a little bit about stimulant use and fentanyl being found in the stimulant supply. So each of our offices, the towns they're located in, the demographic is a little bit different, and certainly the people we serve is different. So Provincetown, we do a lot more with sexual health, and the demographic there usually, especially in summer, it's like a lot of people using stimulants. We provide a lot of condoms, lube, things like that during that time of year and throughout the year too. So, for that, our harm reduction specialists They are educated about fentanyl. They give out the fentanyl test strips. They are certainly educated in, like, even harm reduction with sexual health, things like that too. So we provide that sort of education, fentanyl test strips, just, the smoking supplies have been really popular there. And I think that helps to get people engaged with us who might not have been engaged with us before, now that we're offering that. So I don't know if that's like something specifically we try to outreach for, but we certainly have people adequately trained and in the right spaces where that sort of thing happens. I hope that's a good enough answer.
Yes, thank you. So for this question, do you have any ideas on how society can do more prevention education in schools with teachers? So many people with substance use disorder have suffered horrible trauma as children.
Yeah, 100%. So I just recently over the past, so our work has mostly been funded to work with people who identify as over 18 years of age. Recently, over the past 2 years, because there are such limited services for adolescents here on Cape Cod, I've started working with an alternate peer group program. So these are kids who have either been ordered into this program or it's been recommended, perhaps it's a condition of like probation, etc., to gain some knowledge about substance use, harm reduction, etc. So I've been able to go in and have conversations with those kids about, substance use, the risks of using stimulants, about the pills that we're finding here on Cape Cod, etc. Also harm reduction as pertains to sex. I've also had a really great opportunity to talk with the parents in that group. So being able to work with both has been great. We have, like Bridget said, started to provide some Narcan to the schools, and that's kind of like opened doors. It's a really hard thing to break into, because as receptive as people have been and are starting to be with their understanding of, like, we need to start testing these substances for fentanyl. This is the new reality of how substances look on Cape Cod. And for these age groups, there still tends to be kind of this hanging on, kind of like dare programming mentality. And you always need to be very careful when you're speaking with other people's children about substances and substance use. We find that educating the folks who are the kind of like in-school support systems for these kids is the best way to go about it. So providing supports to guidance counselors who might have questions, like I said, alternate peer groups, having open forum, kind of like parent discussions, providing education to like, I just recently provided some education to a behavioral health group, counseling group that works specifically with teenagers. So now all of those folks in the office know a little bit more about harm reduction and substances and kind of like what's trending in substances around here. So working with the kids is kind of, it's a slow process, but working with their support systems is something that we're definitely always working to do.
Thank you. Would you be able to go into your funding sources for your outreach kids? Do you secure grant funding or pay for your items that way? So many great items. Thanks. That's
a great question. So I think it varies a little bit. We've been doing a lot with our finance team lately to kind of figure out where all of that fits. I know for those outreach kits, we had a grant under the Healing Communities study. So the aim of that study is to reduce opioid overdose deaths by 40% in the community served. So we were a rural community. And we were just kind of communicating with the committee the needs that we were seeing, and we realized there were so many unhoused people. So we were able to allocate a lot of those funds for, the supplies you saw. I forgot to mention that we do have tents, tarps, things like that available. For some reason, the study won't pay explicitly for housing, but that's like, if someone has nowhere else to go, that's really the best we can do sometimes. And we give a lot of that stuff out in Falmouth. So some of that stuff we definitely still have left over. I know our development person is always looking for different grants for us. We have the post-overdose grant as well, which does give us more flexibility for spending for stuff like that. And if you think about prevention or like the demographic we're supposed to be serving, anyone at risk to experience an overdose or has experienced an overdose. And then the same thing for HIV or Hep C, anyone at risk in those categories, we're able to serve and kind of figure out the funding for, but definitely always looking for new opportunities with that sort of stuff.
Yeah, just to like kind of piggyback on that, I think that a lot of the grants that we work with recognize that, creating connection with folks is what's going to keep them coming back. So if somebody doesn't have transportation to get to our office, we might not see them again. So it is important in these grants to kind of account for some like slush fund. We are also like one of the things that I've been tasked with in my position is to represent the harm reduction bucket of funding through like accessing these opioid remediation funds that are now coming through. So what one of my asks is if they are going to be funding our programming and funding harm reduction services that we're providing, that some of that money that we receive will be designated specifically for kind of like slush fund type stuff, like boarding a dog so that somebody can go to a detox, or, just everyday stuff. Paying a phone bill, paying a utility bill, Ubering to an appointment, whatever it is that helps to keep people connected. It is so important to be able to provide kind of like those basic needs. And I think that most of the grants that we access understand that that's a necessity with our folks.
And this probably goes hand in hand with what you just said, but someone did ask, where does the money for cell phones and their monthly fees come from? So I'm assuming as well with your grants.
Yes.
Yep.
Really appreciating this model. Was the person is wondering if your organization has any trainings or processes it has implemented to support staff who are working directly with clients who become violent or cross personal boundaries while interacting with them.
Good question. Yeah, so we do have like a general onboarding process with everyone, and they have to attend certain trainings. And we encourage them to do trainings that may come up, things like motivational interviewing, but kind of like the crisis intervention skills are really important for us to have. So each of our staff has a clinical supervision where they can talk about any issues that may come up. We try to meet as a team once a week, and then we're working on stuff like, if we have to like, unfortunately have a panic button or something like that, if a crisis might happen. And especially if you think about, we're out on a mobile van, there might be two of us in the van. And then if one person comes and like overpowers us, we try to, be prepared for that. We have management usually in those situations that's on site. We never send people out alone either. That's a really important thing. But I don't know, speaking for myself and my experience here, I don't know about Eliza, she might have some more experiences. The people we serve, we tend to have like pretty positive relationships with and ongoing relationships. So even if they may present in a crisis, like, we are people that they trust and they're coming to for a reason. So I think those sorts of things really don't happen as much as people may think. But what do you think, Eliza?
Yeah, oh, definitely. I mean, I would say that the wonderful thing about harm reduction is that like, because we're meeting people where they're at and we don't have any barriers, we don't have any requirements for our services, we're not asking anything of anyone. They're coming to us because they want to, generally. They're coming to us to help fill a need, to assist them. It's not like a doctor's appointment. They're not mandated to be there. They're coming to us because they because they want or need to be there. And I think that generally we form a really good relationship with all of our participants. Have I had experiences where folks are dysregulated due to like substances or mental health stuff? Absolutely. But I think that our staff is pretty adept at kind of like triaging and kind of like, helping to kind of diffuse those crises. We haven't, knock on wood, had anything too major ever happen. People are very, 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 very respectful and grateful for the most part. Yeah.
And have you explored offering PrEP, Hep C treatment, or other meds as part of your mobile work?
Yeah. So right now we are offering same day linkage to those services, but we are in the process of being able to offer those at our sites under medical direction. So that is in the works, and we know that is just going to remove another barrier for folks. Like if we have to send them away with a referral, even if we can provide transportation, if we can provide a cell phone to keep them linked to providers, whatever, there's a chance that in the interim, on the way to that appointment, that we lose them, or they don't end up engaging in care. If we can provide all of those services on site, then I think we're going to be golden. We're going to be able to offer our participants, just that much more wraparound service and fewer barriers to being able to, obtain care for Hep C, MOUD, et cetera. So yeah, we're excited to, start moving along with that.
What percentage of the SSPs now operating in Massachusetts on the map you showed would you estimate are in what's considered a rural area?
I mean, I'm not sure how to answer that. Eliza, what do you think? I know.
Yeah, so I think that like anything that you're seeing, a lot of what you're seeing along the coast there will be more kind of like what you would say is like city or like urban. Anything that's inland from the coast is definitely going to be more rural. Like Western Mass has like some thriving syringe service programs, and their landscape is extremely rural. So I would say most of these, excluding the folks who are kind of on the coast, are going to be more rural.
What curricula do you recommend with youth substance use disorder given increase in fentanyl?
I think for that, so every Narcan training we do, regardless of the audience, we mention like what is currently going on with the drug landscape. So we have many slides that talk about cocaine, like basically fentanyl found in different drug supplies, or like counterfeit pills or stimulants or things like that. So we really, really try to educate and drive that point home. We also offer the fentanyl testing kits. Those seem to be really popular with people. I had people stop by at the service center and get them because they have like a child who's away in college or something like that. So, we never mean to like scare anyone or like, invoke fear to get people to stop doing something. But I think it's really important to at least, tell people what's happening with like, especially cocaine and fentanyl. I know, and I've heard of several people who have, died from an overdose that way because they weren't expecting to have fentanyl in, the line of cocaine they were doing, or if they're smoking crack or something like that. So, the education piece and just being realistic about what's out there, I think is important. And then also, harm reduction around what's out there, because people will decide to do what they're going to do, regardless of what people may try to tell them. Yeah.
And any recommendations with how to deal with xylazine overdose after Narcan administration?
Sure, I can talk about that. So the way we respond to an overdose where xylazine is on board, so xylazine is an animal tranquilizer. It was tested on humans, not approved for human use, just because the effects were so variable from person to person. Xylazine is a tranquilizer, and so it further depresses respiration when folks are experiencing an overdose. So we know that when someone is experiencing an opiate overdose, what happens is respiration is depressed. Tranquilizer effect will further depress respiration. Because Narcan only works on opiates, it obviously will not reverse the effects of xylazine. So that's something that people need to just be supervised for. We always advise people that when you're responding to an overdose and you are making the assumption that xylazine is on board, because people will appear to be much more out of it. They will still be breathing. So once you revive somebody using Narcan, the object of using Narcan obviously is to get people breathing again. So once somebody starts breathing, you're going to expect that they're going to still be experiencing the effects of that tranquilizer. So they will appear to still be out of it for a much longer period of time. If they are breathing, if they're slightly responsive, you don't have to administer more Narcan, but our advice is that you really sit with that individual, you wait until they start to come back around and you really, really monitor respirations. People who have xylosine on board when they experience an overdose oftentimes will need some chest compressions and will need mouth-to-mouth breathing. So be ready to do rescue breathing. Don't onboard more Narcan if it's not necessary, but just expect that they're going to appear harder to bring around.
We are nearing the end, but I do have a few more questions in the chat that I want to present to you both before we close today's session. Any idea of the cost of the court cases to get your health provision and life-saving service going?
As far as getting approval in the different towns, or as far as our kind of like landmark decision with versus the town of Barnstable, is that what we're talking about? I'm not sure.
Probably the latter, I think.
So if you're talking about our kind of like groundbreaking, court case with us versus the town of Barnstable to establish our syringe services there or to continue them there, I do believe that a lot of the work that was done on our behalf was pro bono because of our relationship with the folks who supported us and because of the work that we do. GLAD was a big supporter of us, remaining in operation. So I think that we received a lot of supportive services there.
Any idea of how many of your clients have FASD, ADHD, ASD, or mental health issues?
I mean, I would say to that question, I'm sure some, but we don't really track that, nor do we ask that of people. We're not, clinical staff by any means. So really the way people present, we have trainings in how to interact with people or, identify risky behavior, or if someone may appear, more out of it. We get people who come to us in all states, whether they're intoxicated, high on a substance, something like that. So, it's not necessarily our work to address those things, but I think our staff is trained in just how to respond compassionately and appropriately in a given situation.
Yeah, we also have a pretty diverse staff here.
Yeah.
I think a lot of our staff identifies as, ADHD, ASD, and I think that we have some, we have that perspective. We also, most of us come from, family or, networks that have experience with those issues. I would say that most of our clients have some sort of a co-occurring something, whether they choose to identify it or not. Lots of people are really open with us about that. Others are not. So yeah, just making sure that everybody's trained and everybody's compassionate and that we have a diverse staff on board who, we can all learn from each other.
And I know now we are at the end, but just the last question, do you have any specific, have you found any specific personality types that work best in your field of work? Clearly, you are both very dedicated people.
Yeah, that's a good question. Our interview process, we're on Cape Cod, so, the pool of candidates might be a little bit more limited, but, in our interview process, we really try to ask questions that might be actual scenarios that happen. So we try to screen that way. We do obviously look for people who may have lived experience. We understand that if you look at someone's resume, it might not capture everything about why they want to do this work. So, just kind of asking people, what made you apply for this position specifically, or, what interests you about this field? What is harm reduction to you? Things like that. But, sometimes you don't know how it will go until the person's with you also, and that's okay.
Yeah, you can't train people to be calm under pressure either. And so you can usually get that sense from people. That's really important to us, that they have a pretty kind of even chill demeanor. That's important to our participants as well. So.
Well, and I lied. The last question I saved the best for last. Eliza, where did you get your sweatshirt? That seems to be, it's very nice. And I think we're all very interested.
I wish I remembered. I've had it for so long. I don't know. I'm sorry. Yeah,
But
probably,
thank you for sharing it with us and wearing it. It's a great
Yeah,
sweatshirt.
well, I
perfect.
had to put it on because I have an obscene t-shirt underneath it. So
Oh,
sorry. Yeah, maybe an Etsy shop a long time ago.
yeah.
Yeah.
Very nice.
Search it on it. Search it on Etsy. You'll find one, maybe not the same,
Yeah.
but like it. Yeah.
Well, thank you both so much. We really appreciate all your time and you know, again, your dedication and being with us. We also want to thank all our participants for being here today. As a reminder, we ask that you please complete the survey, whether or not you're looking for CEs or certificate of attendance. We really would love your feedback, and we're actually going to be sharing that feedback with our presenters as well. So I think it'll definitely help as we all prepare for future presentations. I have also left some information if you're interested to join us on the next session in our series, the Expanding Harm Reduction in Rural Appalachian, Ohio. That will be on Friday, May 5th at 12 p.m. Eastern time. So vary based on your time zone. So thank you all very much, and we wish you a wonderful day, and we hope to see you next month. Thank you.
Thank you,
Take care.
everyone.
Thanks, everyone.
Bye.